welcome back, friends. Now we are going to discuss the next topic on vascular surgery. One of the important chapter for PG entrance exams is this vascular surgery. In this we have three systems: arterial system, venous system, and lymphatic system. Let us start our discussion from arterial system. So we are going to start from arterial system first discussion. So let me start with aneurysms. So one of the important topic in arterial system is aneurysms. So aneurysms are very important topic for your exams. So first of all, you should know what is aneurysm and what is the important differential diagnosis of aneurysm. The important differential diagnosis is ectasia. Aneurysm and ectasia. What is the difference? Aneurysm is the blood vessel is dilated more than 50% of diameter. More than 50% of the diameter, the blood vessel is dilated, is aneurysm. If it is less than 50% dilated, it is ectasia. For example, if the blood vessel is 1 centimeter normal diameter, if it is more than 1.5 centimeter, it is aneurysm. It is less than 1.5 centimeter, it is ectasia. The most common mechanism of aneurysm, the most common etiology is atherosclerosis. So please don't forget, the most common reason is atherosclerosis. You want to remember this? Okay, atherosclerosis is the most common reason for aneurysms. So now certain definitions and certain important MCQ one-liners I'm going to tell you. So aneurysms, what is the most common site overall in your body? Most common site is circle of Willis. The most common site is circle of Willis. And if they ask you what is the most common extracranial site of aneurysm, so most common extracranial site of aneurysm is abdominal aorta. Please don't forget this question. So the most common extracranial site of aneurysm is abdominal aorta, usually infrarenal. Usually it is infrarenal. Abdominal aorta is the most common site of extracranial aneurysm. Most common site of peripheral artery aneurysm, it is popliteal artery. It is popliteal artery. Most common site of visceral artery aneurysm. Where is it? Visceral artery aneurysm is splenic artery. Splenic artery. Mycotic aneurysm is a misnomer. It is not caused by fungus. It is caused by staphylococcus. Mycotic aneurysm is a misnomer caused by bacteria, not fungus. So this is most common in femoral artery. It is common in femoral artery. So please don't forget this basic one-liner points for your exam. The most common sites of each aneurysm. So in this, let me tell you, the other methods of classification are we can divide the aneurysm into true and false aneurysms. True aneurysm is an aneurysm which contains, true aneurysm is an aneurysm which is containing all the layers. All the layers are present. So all the layers are present. Tunica, intima, media, adventitia, every layer is present. That is true aneurysm. False aneurysm may lack one or two layers. So false aneurysm is one which will lack one or two layers. It will not have all the layers. So this is one classification, true and false aneurysm. So another classification is like this. The aneurysm may be fusiform aneurysm like this. So this is fusiform, like a fusiform, symmetrical enlargement is known as fusiform shape aneurysms. And what is the shape of this aneurysm known as? This is saccular aneurysm. It is like a diverticulum. It is like a diverticulum from the bowel. A saccular aneurysm is very dangerous because high chances of rupture is present. It can rupture. So fusiform aneurysm, saccular aneurysm. And what is this aneurysm I'm drawing? You tell me. Blood tracks between the layers. Blood tracks in the layer through the tunica intima. Going into the tunica intima, it is known as dissecting aneurysm. So dissecting aneurysm. So please don't forget there are three types of aneurysms I want to discuss. Fusiform dilatation of aneurysm is a symmetrical enlargement of blood vessel. Saccular is like a diverticulum. It is separately coming out. Okay, it is a asymmetrical enlargement. It's only one part of blood vessel is enlarged. And dissecting aneurysm is one in which the dissection happens in the layers of blood vessel. Okay. Now let me first discuss with abdominal aortic aneurysm because every year there is question from only this. Abdominal aortic aneurysms. So please don't forget, abdominal aortic aneurysm is most commonly located below the renal arteries. It is usually located like this. It is usually located below the renal artery. It is usually located like this. It is usually located infrarenal. The aneurysms are usually located infrarenal. They are located infrarenal. The most common presentation is back pain. They commonly get back pain. The reason we are very much worried about this aneurysm is it can go for rupture of aneurysm. It can go for rupture. So the rupture can be two places. Either it can rupture anteriorly or posterolaterally. So it can rupture posterolateral. The major issue with aneurysm is it can rupture either anteriorly or posterolaterally. Anterior rupture is 20% and posterolateral rupture is 80%. And you can easily, from the picture itself, you can say if the aneurysm ruptures anteriorly, it has enormous space in the peritoneal cavity and the patient will die in the spot itself. He will not come to hospital. He die in spot. Die in spot. Okay, anterior ruptures will die in spot. Whereas posterolateral aneurysm, there is a retroperitoneal space. Therefore, the aneurysm will be compressed by a hematoma. Therefore, they will not die. They will come to you with a pain, shock, back pain and shock. Severe back pain and a shock. In Western countries, any old age patient coming with a back pain and shock, they will think of only posterolateral rupture of aneurysms. So please don't forget, they immediately come to hospital and they also have high mortality, but still you can save them. They have high mortality, but still you can save these cases. So please don't forget the most common complication is rupture of aneurysm. So now, what is the investigation of choice for abdominal aortic aneurysms? So it is CT angiography. CT angiography is an investigation of choice because it gives you a roadmap of how to manage aneurysms, also given by this CT angiography. But on ultrasound, we keep them on follow-up. If already one abdominal aneurysm is diagnosed, ultrasound is used for follow-up. Just ultrasound is enough for follow-up of the patients. When will you intervene an abdominal aortic aneurysm? When will you operate? Indications of management, indications of treatment. I'm not telling surgery, I'm telling indications of treatment of abdominal aortic aneurysm are number one. Any symptomatic patient, please remember, any symptomatic patient you must operate. Any symptomatic patient having a back pain and typically having some symptoms of aneurysm. Two, asymptomatic patients we operate. When will you operate an asymptomatic aneurysm on ultrasound? When the anterior-posterior diameter, please remember it is not lateral diameter. Many people are thinking as lateral diameter. It is not like that. It is anterior-posterior diameter. The anterior-posterior diameter is more than 55 mm. Last year MCQ, 2020 MCQ. When it is more than 55 mm means what is it? 5.5 centimeter is the cutoff. The management cutoff for abdominal aortic aneurysm is 5.5 centimeter. Any aneurysm more than 5.5 centimeter needs treatment. Okay, asymptomatic aneurysms and asymptomatic aneurysm more than 5.5 centimeters will be treated. So until 5.5 centimeters, we can keep them on follow-up if they are asymptomatic. If they are asymptomatic, less than 5.5 centimeters, keep them under follow-up. That's enough. No need to do surgery going and doing surgery is not advised. So the treatment done, conventional treatment done for these patients for abdominal aortic aneurysms, the conventional treatment done is we will resect the aneurysm. We will resect the aneurysm. For example, if this is aneurysm, we will resect the aneurysm out. And then we use a graft made up of dacron. We use a graft made up of dacron like this. This is looking like what? This is a dacron graft looking like a pant. It is looking like a pant. It is looking like a pant. Therefore, it is known as dacron pant graft. Dacron pant graft is used for replacing abdominal aortic aneurysm. After resecting the aneurysm, the dacron pant graft, I'll show you the image, was used in those days. But today, there is no need of this much of major operation. This type of major operations are not at all needed now. So what we are doing now? We are doing now endovascular procedure. So the conventional removal of aneurysm is not done now. Conventional removal is not done nowadays. So resection of aneurysm is not done nowadays. So if you do the conventional operation of resection, what are the complications you can get? So the complications, very important. The complications because of doing such a major operation, the most common cause of death in these patients. During surgery, they may suddenly develop MI and die. Most common cause of death is MI. Other problems are renal failure, leak of the graft, and the patients may develop colonic ischemia. Colonic ischemia may develop if you are not properly reimplanting the inferior mesenteric artery. The patients may have colonic ischemia. You should look for the SME-IMA collaterals before doing the before coming out of the case. So colonic ischemia may happen, and please don't forget there will be injury of artery of Adam Kiewicz. Artery of Adam Kiewicz. It is an artery supplying the spinal cord. It is an artery supplying the spinal cord arising from posterior intercostal artery. Arising from posterior intercostal artery. This supplies the anterior part of spinal cord, and if this vessel gets damaged, patient may develop anterior spinal artery syndrome. Anterior spinal artery syndrome known as paraplegia. That will result in paraplegia. So please don't forget injury of artery of Adam Kiewicz. Artery of Adam Kiewicz is a branch from posterior intercostal artery, and as this gets damaged, you get anterior spinal artery syndrome. That will result in paraplegia. This artery of Adam Kiewicz can also be damaged in esophageal operations. So please remember, it can also be damaged in esophageal operations. So the mortality of this type of cases, elective cases will have 2%, and emergency cases will have 50% mortality. Emergency cases of ruptures will have 50% mortality in these operations. So please don't forget, the surgical treatment is not done nowadays. The latest treatment is EVAR. So what is EVAR? Endovascular aneurysm repair. To show you the image later, but please remember what we will do here is, if this is aneurysm like this, by going through the blood vessel, they keep a stent inside like this. They keep a stent inside the blood vessel like this. Same like pant graft, they keep it inside like this. So the blood vessel will slowly flow on through this way, and the aneurysm collapses. This is what EVA, endovascular aneurysm repair. So just for completion's sake, but not being done, is known as Hunterian ligature. Hunterian ligature operation was done in those days. So if there is an aneurysm like this, what they used to do is, leaving the blood vessel above and below, they ligate the aneurysm up and down. They don't remove, just ligate it. As they ligate, the aneurysm collapses. This was done in those days, but not advised now because of the various ischemia developing. Hunterian ligature for aneurysms is abandoned now. It's not done anymore hereafter. It is not done anymore hereafter. Please don't forget, just remember the name alone. So anyhow, the materials used in this aneurysm repair is dacron. Dacron is the material used. We can also use polytetrafluoroethylene, and the suture used is what? What is the suture material used? We use, this is the typical PG entrance question, 30 or 40 proline. We use 30 or 40 proline for suturing the abdominal aorta. Please don't forget, for suturing the abdominal aorta, we use 30 or 40 proline. Aorta with the graft, we use 30 or 40 proline for sutures. So this is one common seen aneurysm. So the next aneurysm is aortic dissection aneurysm. Aortic dissecting aneurysm. So in this, what happens? This is an arch of aorta. This is descending aorta, ascending, descending arch. Okay, this is, now what happens here is, on the right lateral wall, there is a tear happening. There is a tear happening in the right lateral wall. Tunica intima level. Tunica intima level. Please understand. Tunica intima level. Right lateral wall. What type of tear? There is a transverse tear which happens. This is the most common site of dissection beginning. So there is a dissection starts here like this, and immediately you can see the blood will track in the between the layers, and it will flow like this. And either it will reopen somewhere into the artery like this. Somewhere it will reopen, or if it is not reopening, it will compress the vessel, and it can cause multiple other problems. So please don't forget aortic dissection aneurysms. The dissection most commonly starts from right lateral wall. It is a transverse tear of tunica intima. It is most commonly seen in men at the age of 60 to 70 years. And the most common risk factor is hypertension. So please remember, hypertension is the most common risk factor. And other risk factors are Marfan syndrome, Ehlers-Danlos syndrome. What are the other risk factors? Marfan syndrome, Ehlers-Danlos syndrome, Takayasu's arthritis, Takayasu, coarctation of aorta. So many other causes are there. The patient presents to hospital with severe pain, hypotension, and if sometimes myocardial infarction will develop if coronary ostium involved. Myocardial infarction will develop if coronary ostium is involved in the dissection. So when you take X-ray chest, that will show you widened mediastinum. Please remember, X-ray chest will show you widened mediastinum. So investigation of choice for a stable patient is CECT thorax. CECT thorax is done for stable patients. Unstable patients for whom there is no time for CT scan to confirm the diagnosis, we do transesophageal echo. Please don't forget, transesophageal echo is done for unstable patients. So unstable patients. On a CT scan, we can diagnose the type of tear by a classification known as D-Bucky classification. D-Bucky classification. So very simple classification. Please understand this. I'm drawing the normal anatomy. Arch of aorta, ascending aorta, descending aorta, arch of aorta, descending aorta. Now see, in D-Bucky type 1, the dissection involves ascending aorta, arch of aorta, as well as descending aorta like this. This is D-Bucky type 1. In type 1, all vessels are involved, ascending, arch, descending. Type 2, only ascending, is a very smallest tear, so involving only the ascending aorta, that's all. 3 is the one which is involving only the descending aorta. Only involves descending aorta is 3. So D-Bucky classification 1 and 2 are now named as Stanford A. D-Bucky 1 and 2 are now known as Stanford A. 3 is known as Stanford B, Stanford classification B. So very simple to remember. A means it will involve ascending iota. That's all. A means involves ascending iota. Whenever ascending iota is involved, we call it as Stanford A. When ascending iota not involved, it is Stanford B, simple classification. Otherwise, D Bucky 3 is now known as Stanford B, D Bucky 1 and 2 are known as Stanford A. So this classification is a definite question for you. So in dissecting aneurysms, please don't forget, you will definitely get this question in exam. At this point, I want to tell you one important clinical feature which we have already discussed in trauma. What is a classical clinical feature? The patient will have pain, shock, and when you measure BP, there is disproportionate BP in the upper limb. Okay, there is disproportionate BP between the upper limbs or between upper limb and lower limb. Please don't forget, there will be disproportionate BP between upper limbs and between upper limb and lower limb. There will be disproportionate BP between the upper limbs or between upper limb and lower limb. There will be disproportionate BP. This is a classical MCQ. So please don't forget, in a dissecting aneurysm, the immediate treatment is surgery. Immediately the patient should be taken up for thoracotomy and plan a Dacron graft being done. Dacron graft is done. So Dacron grafting is done immediately. Please don't forget, emergency Dacron graft repair is done at the earliest for these aneurysms. So these are the two important things, and for those who are preparing for super specialty level, there is one more classification known as Crawford classification. Crawford classification of thoraco-abdominal aortic aneurysms. Thoraco-abdominal, it is there in substance but not in variant law. Thoraco-abdominal aortic aneurysms have a classification known as Crawford classification. In dissecting aneurysm, what is the most common site of tear? In the right lateral wall of ascending aorta. Please don't forget it. In dissecting aneurysm, I forgot to tell you, the second common site of tear will be seen distal to the ligamentum arteriosum. In the descending aorta, second common site. The second common site is in the second most common site is distal to ligamentum arteriosum. That is second common site. So you have to remember certain site and all. You should not forget in aneurysms because the question will be only on sites. So Crawford classification is divided into 1, type 2, type 3, and type 4. So this is going to explain about thoraco-abdominal aneurysms. So let me draw you the full picture now. So I am drawing the full picture up to bifurcation. I am drawing here. Ascending aorta up to bifurcation of aorta I am drawing now, so that you will understand the Crawford aneurysms. So nothing to mark up. It is also a simple topic only, but you have to revise it. Otherwise you will forget it. So now see, Crawford A. Crawford A is an aneurysm which is seen. What is this vessel? What is this vessel? Left subclavian artery, which is seen from left subclavian artery to renal artery level. So this is renal artery level. So one is an aneurysm which is seen from left subclavian artery level to renal artery level. That's all. Up to renal artery level. This is Crawford type 1. Crawford type 2 is the biggest aneurysm. It will extend from left subclavian artery to the bifurcation of vessels. It will extend up to the bifurcation of vessels. This is 2. Please don't forget 2. 2 is the biggest one. It extends up to the bifurcation. Most largest aneurysm is this. 3 is from mid descending aorta to bifurcation. From mid descending aorta, not from left subclavian artery. From middle of descending aorta to bifurcation is 3. Okay. So 4 is a condition which is not present in thorax. Though I am discussing thoraco-abdominal aneurysms, it is not present in thorax. Please remember, it will involve suprarenal. So we have already discussed infrarenal. It will involve suprarenal, upper, and it may involve renal artery also. It may or may not involve the renal artery also. So it is upper abdominal aortic aneurysm. So one is left subclavian artery to renal artery, left subclavian artery to bifurcation, from middle of descending aorta to bifurcation. So it is suprarenal aortic aneurysm is this. So these are the 4 types of abdominal aortic aneurysms I want you to remember in Crawford classification of thoraco-abdominal aneurysms. So then comes the peripheral artery aneurysm. So others are not so important. Just for completion telling, popliteal artery aneurysm is the most common peripheral artery aneurysm. It is mostly bilateral. Please remember, 2/3 times it will be bilateral. It may form thrombus and it can cause distal obstruction of the limb. So we can wait up to 25 millimeters. We can wait. Above 25 millimeters, we have to operate a popliteal artery aneurysm. Okay. So the major issue with popliteal artery aneurysm is embolus or thrombus can form and it can cause distal occlusion. Distal occlusion. And I already discussed you about the mycotic aneurysm. So mycotic aneurysm is caused by staphylococcus. Mycotic aneurysm is caused by staphylococcus. So please don't forget, it is caused by staphylococcus. It is usually seen in femoral artery because many times the house agents or the residents go and take blood from the femoral artery without proper sterile precaution. That results in fungal infection going inside. It is a femoral artery aneurysm and it is false aneurysm. Please don't forget, it is false aneurysms. So these are the various aneurysms I want you to remember. Let me show you the images. So please don't forget, aneurysm is a small topic but full of MCQs. You should not forget the MCQs. See the picture showing you infrarenal abdominal aortic aneurysm. This is the most common site. You can see the CT angio picture of infrarenal aneurysm. This is a reconstructed MR angio showing clearly the anatomy. So you can see that pant graph. This is one of the images taken when I was doing emergency long back. Such a huge abdominal aneurysm resected. You can see pant graph being kept inside. So the complications, please don't forget, the most common cause of death is MI. So this is endovascular aneurysm repair, which is stent is kept inside. Endovascular aneurysm repair. Don't forget D Bucky, ascending, descending. Ascending alone is 2, descending alone is 3. Stanford A stands for ascending aneurysms. Okay, this is Crawford, I told you, which is the biggest one. B is the biggest one. B is the biggest one. You can see involves all the layers. All the vessels like subclavian artery onwards, thoracic, abdominal up to bifurcation. Second is the biggest vessel. Okay, so this is a popliteal aneurysm on both limbs. Okay, so this completes the aneurysm topic. So we'll go to next other topics. So now I'm going to discuss one important topic in arterial system, that is acute limb ischemia. Acute limb ischemia. So the most common cause of this acute limb ischemia is from an embolus arising from left atrium. So left atrial thrombus gets disconnected and comes down and obstructs the lower limb vessels. The classical symptom of this acute limb ischemia is 6P: pain, paresthesia, pulselessness, there is absence of pulse, poikilothermia. Poikilothermia means that limb is having less temperature than the normal limb, so it is cold. The limb is cold. So compared to the normal limb, it is cold. Pain, paresthesia, pulseless, poikilothermia, paralysis of the limb, and the limb looks paler because of occlusion of the blood vessel. It looks paler. So it is an emergency. Please remember, it is an emergency. Within 4 to 6 hours, you have to intervene. Within 4 to 6 hours you have to intervene, otherwise the limb will be gone. So please don't forget, within 4 to 6 hours what will I do? Yes, I'm going to explain now. So let us assume this is aorta, this is common iliac artery, this is external iliac artery, this is internal iliac artery. So this external iliac artery continuing as femoral artery, popliteal artery like that, superficial femoral artery, popliteal artery like that. So now let us assume the thrombus is in this place. The thrombus is in the superficial femoral artery, that is a embolus. Embolus is getting obstructed here, causing the blood vessel flow obstruction. So what I will do is, I will put a Seldinger technique. I will use now Seldinger technique. By Seldinger technique, what is this technique? In Seldinger technique, what I will do is, I will cannulate the artery. I will cannulate the artery in a retrograde way. In a retrograde way, using special needle known as Seldinger needle, I will cannulate and I will pass the guide wire distal to the embolus like this. Distal to the embolus, I will pass a guide wire like this, and through this guide wire, I will pass a balloon. What is the name of that balloon? I will pass a balloon. That balloon will be inflated, and now I will withdraw the catheter. That balloon catheter I will withdraw. That catheter is known as Fogarty balloon catheter. Fogarty balloon catheter, I will withdraw it back. As I am withdrawing it, I will remove the embolus through a small incision in the artery. This should be done in 4 to 6 hours. This procedure is known as embolectomy. So this procedure is known as embolectomy, usually done with the help of Fogarty balloon catheter. If you delay this procedure, the patient will end up in limb gangrene. So please remember, it should be done at the earliest. If already the limb is gone for gangrene, there is no use. We have to do only amputation of the gangrenous part of limb. So please remember, it is an emergency. It's a surgical emergency. Immediately, we have to do embolectomy in 4 to 6 hours. So this is an acute limb ischemia. So that is chronic limb ischemia is the next topic. Chronic limb ischemia is the next topic. So please don't forget, next topic is on chronic limb ischemia. Chronic limb ischemia is mainly by peripheral vascular disease. It's caused by peripheral vascular disease or by means of thromboangiitis obliterans. These are the two important causes of chronic limb ischemia. I'm going to discuss. You will get such a clear clarity in this next 30 minutes about peripheral limb ischemia in chronic cases. Please focus for next 30 minutes. Don't get deviation and focus this topic. So in app-based preparation, the most important thing is preparing and seeing the topic in a full stretch. You should not give a break in the topic. If you give breaks, multiple, it is not a movie. You should break and go and see after some time. It is not possible. If you do like that, the flow of the chapter will be gone. So to maintain the flow of chapter, you have to sit and see the app, the topic fully in a single stretch. So peripheral vascular disease and TAO, the basic differences, let me tell you. Basics between these two. Peripheral vascular disease, what are the causative factors? Can you tell me? So the causative factors are enormous. Like what are the causes of atherosclerosis? Like diabetes mellitus, hypertension, hypercholesterolemia, obesity. It goes on. Whatever cause you know, hypercholesterolemia, hypertension, diabetes, all these are various causative factors of peripheral vascular disease. Okay, peripheral vascular disease resulting in atherosclerosis and obstruction of the blood flow. So this is one topic, atherosclerosis of the lower limb. And the other one, TAO. The main cause is only smoking. Only smoking. There is no other risk factor. Only smoking is a risk factor. And in this peripheral vascular disease, the major problem happening is thrombus. Thrombus formed in vessels. In peripheral vascular disease due to atherosclerotic lesions, thrombus is occluding the vessels. Please don't forget, thrombus is occluding the vessels. Whereas in TAO, there is no thrombus. The vessels are getting occluded by vasospasm. The vessels are getting occluded by vasospasm. So please understand the basic difference between atherosclerotic lower limb disease and TAO, thromboangiitis obliterans. I'm going to discuss both in separate discussion. Just have an idea about it. Peripheral vascular disease caused by atherosclerosis mainly involves major vessels like aorta, common iliac artery, or external iliac artery, or femoral artery, superficial femoral artery. It involves major vessels most commonly. So atherosclerotic occlusion involves major vessels most commonly, whereas TAO will involve, this is superficial femoral artery, this is popliteal artery, and from popliteal artery, this is anterior tibial and this is posterior tibial. It will involve infrapopliteal only. It will involve infrapopliteal lesions. It is involving infrapopliteal, and atherosclerosis will be unilateral or bilateral, whereas TAO is always bilateral, symmetrical. It will be bilateral and symmetrical. Atherosclerotic disease is common in old age, as you know very well. It is common in old age. TAO common in young age, less than 50 years, and it is only seen in male. It is seen in males, exclusively males. Not at all seen in females. Not at all seen in females. It is more common in male. Atherosclerosis is more common in male than females. Okay, more common in men than women. Whereas here it is exclusively common in men. Upper limb not affected. In atherosclerosis, upper limb is not affected, but in this condition, upper limb is also affected. Upper limb is also affected, and adjacent veins and nerves are not affected in atherosclerosis. Whereas in TAO, adjacent veins and nerves are also affected. Adjacent veins and nerves are also affected in TAO. Okay, are also affected in TAO. So these are the two important diseases. Have this basic outline between atherosclerosis and TAO. What are the basic outline? Atherosclerosis is caused by various risk factors. TAO only one risk factor, that is smoking. Atherosclerosis is caused by thrombotic occlusions. TAO is due to vasospasm involving infrapopliteal only. And TAO is bilaterally symmetrical. It is common in young males only. Interesting point is TAO involves upper limb. Adjacent veins and nerves are also affected. All these are interesting points on TAO. Now, both these patients presents with what are the clinical features of these two patients. So now this is a typical discussion for final year students. Final year students presenting atherosclerotic lower limb disease or TAO, you should understand these clinical features. They present to you with intermittent claudication. They present to you with intermittent claudication pain. Define claudication pain. Claudication pain is defined as pain is not present at rest. Pain not present at rest. So pain starts on walking. Pain starts on walking. Pain is not present on standing. Please remember, pain not present on standing. It is not present on just simply standing, but it starts on walking. This is known as claudication pain, and the pain decreases on rest. Pain decreases on rest. So this is definition of intermittent claudication pain. So pain is not present at rest. Patient is having rest, not having pain. Once he is starting to walk, pain happens, and as he takes rest, pain disappears. So this is classical claudication pain. So you should not get confused with the neurogenic claudication. If it is a neurogenic cause of pain, neurogenic claudication pain or neurogenic pain, the pain will increase on when? On standing up. Increased on standing up. Whereas intermittent claudication pain of vascular occlusion, pain is not present. Neurogenic claudication increased on standing. The pain increased on standing. And the most common site of claudication pain is cough. Why is it in cough? Because the most common site of occlusion is where? Most common site of occlusion is superficial femoral artery. Superficial femoral artery is the most common site of occlusion. That is the most common site of occlusion. So the patients will have more of pain in the cough. So please don't forget they will have pain more in the cough. And regarding the claudication pains, regarding various claudication pains, I want to tell because this question came in National Board Exam 2020. So claudication pain, where is it present and how is it presenting? That point you should not forget. So claudication pain in buttock, both thigh, both cough. Where is the obstruction? Can you tell me? That is the question came in exam. So buttock, both thigh and cough. So the occlusion is where? The occlusion is at aortoiliac occlusion. Aortoiliac. The occlusion is involving aorta and bilateral iliac vessel. So bilateral thigh and cough. The occlusion is aortoiliac occlusion. Patient complains of pain in one thigh and one cough, and even sometimes buttock. It is very rarely in buttock, not always. It is unilateral common iliac artery occlusion. Unilateral common iliac artery occlusion. Buttock, one thigh, one cough. Only in thigh and cough, it is usually external iliac artery occlusion. Only in cough, it is usually in superficial femoral artery or popliteal artery occlusions. So this is an expected MCQ. Based on the occlusion point, you have different pain. So the question asked in exam in 2020 is a patient presenting to you with a clinical question had a pain in the buttock, both thigh and both cough. Where is occlusion means it is aorta and by common iliac both sides is involved. Bilateral iliac and aorta occluded will cause this pain. At this point, let me tell you one interesting syndrome, Lerick syndrome. What is it? What is Lerick syndrome? Please don't forget this is an expected MCQ again and again repeatedly asked. So this is an aortic bifurcation. At the bifurcation level, there is a saddle-shaped thrombus sitting like this. There is a saddle-shaped thrombus. So what it will do? There is a saddle-shaped thrombus sitting on the bifurcation. It will cause buttock claudication. It will cause buttock claudication and what else? And impotence. It will cause buttock claudication and impotence. This is known as Lerick syndrome. So please don't forget buttock claudication and impotence is seen in Lerick syndrome patients. So these are the various clinical features of atherosclerotic lower limb disease. And at this time, I want you to remember about Boyd's clinical classification of claudication pain. Boyd's clinical classification of claudication, in which there is grade 1. Grade 1 is a condition. Patient starts walking. Okay, patient starts walking. He develops pain. He develops pain in the lower limb. He walks with the pain. Pain disappears. So pain disappears. It is grade 1 claudication pain. Pain disappears. Grade 2. The patient starts walking. Pain appears. He walks with the limp. He walks with the limp. So walks with limp. This question has come in the exam. A patient with a claudication pain walks with a limp is diagnostic of grade 2 claudication pain. Grade 3 claudication pain. The patient starts walking. He gets pain. He's unable to walk. He takes rest. He's unable to walk. He takes rest. Compels to take rest. Compels to sit. He's unable to walk. He has so much of pain. So he's simply sitting. That is 3. 4 is the patient is having rest pain. Simply sitting itself is having pain. Rest pain present. So this is Boyd's classification of claudication pain. So this is a repeat question. Boyd's classification of claudication pain. Who walks with a limp? Please don't forget. The guy grade 2 walks with a limp. With a painful limp he walks. What are the other classification systems? From Sabiston, there are many other classification systems given for claudication. Just let me tell you the name: Fontaine classification and Rutherford classification. Fontaine and Rutherford classification are the two other classification systems. So Fontaine and Rutherford are the two other classification systems given in Sabiston. So no need to remember all those factors inside, just know the name. Okay. So now we have completed the clinical examination. At the end of clinical examination, we do one test known as ankle brachial pressure index. At the end of clinical examination, we measure ankle pressure divided by brachial pressure. So normally ankle pressure is 120/80, brachial pressure is 120/80. So the normal value will be 0.9 to 1.1. That is the normal value. So it will be normal value will be 0.9 to 1.1 will be the normal value. If the ankle pressure is low due to occlusion, if there is an ankle pressure low due to occlusion, naturally, if there is a less than 0.9 value means patient is having claudication or some occlusion. If it is less than 0.9, he is having claudication. If it is less than 0.5, he will have rest pain. And if he is having less than 0.3, it is imminent necrosis. Limb is gone or is about to be gone. Immediately we have to intervene. So less than 0.9 is claudication pain, less than 0.5 is rest pain, less than 0.3 is imminent necrosis. Here there is an expected question from Bay and Low. Who will have false high value more than 1.3? ABPA more than 1.3 is false high because of calcified vessels, calcified arteries. Who will get like this? Diabetes mellitus and CKD patients. In CKD and diabetes mellitus, the blood vessels will be calcified in the lower limb. So therefore, even if you raise the cuff, the vessel cannot be occluded. Therefore, it is a false value. That is a false high value more than 1.3. Otherwise, usually we don't get lower limb more pressure than upper limb. That is not possible. So it is even calcified arteries, you get this finding. Please remember this point. So this is ankle brachial pressure index. So now we are coming to the investigations of vascular disease. So investigations of vascular disease, the first done investigation always is color Doppler. Please don't forget. The first done investigation is always color Doppler will be done. That is known as duplex scan. That is the first done investigation. It's a non-invasive test. It is a repetitive. It can be repetitive and non-invasive. Non-invasive and repetitive. But if they ask you what is the gold standard investigation for atherosclerotic disease, gold standard investigation is CT angiography. CT angiography is a gold standard investigation because this acts as a roadmap for our planning. So it acts as a roadmap. So we can either plan surgery or we can plan bypass or we can plan stenting. Everything can be possible only with the CT angiography. It acts as a roadmap. Please don't forget. Therefore, CT angiography is done all the patients before surgery or any intervention. So now let us assume the patient has occlusions in some of the places as I'm drawing. So external iliac artery, superficial femoral artery. Please understand, I'm going to show you an important thing. So popliteal artery, anterior tibial, posterior tibial artery, anterior tibial, posterior. This is an arterial tree of lower limb. Now if there is a thrombus in the aorta like this, if the occlusion is at the aorta like this, or if there is an occlusion in the common iliac like this, or the occlusion is in the superficial femoral artery, or it is in the popliteal artery, These are the places where you can get atherosclerotic occlusions due to thrombus. In olden days, what we used to do? In olden days, the treatment done for these patients is bypass operations. We will do bypass operations. So bypass operations are done with the following materials, either with Dacron, polytetrafluoroethylene, or patient's own saphenous vein, which can be two types: in situ saphenous vein or reverse saphenous vein. Very important topic I'm discussing. Please don't forget. So in situ saphenous vein and reverse saphenous vein. So what are the ideal materials for aortic replacement and aorta bypass, like aortoiliac like this? We use Dacron. Aortoiliac or aortic replacement, Dacron is best. So Dacron is best for aortic replacements. And usually for aorta we use 30 or 40 proline to fix the sutures. Aorta we use 30 or 40 proline. And for iliofemoral bypass, okay, iliofemoral bypass from iliac artery to femoral artery, we use polytetrafluoroethylene. For femoral artery bypasses. For femoral artery bypasses, we use polytetrafluoroethylene, and the suture material is 50 proline. Suture material is 50 proline is used for suturing with the femoral artery. And infrainguinal, this is an MCQ. This is inguinal ligament. If you want to do bypass for infrainguinal from here onwards, femorotibial or femoropopliteal, these things we use patient's own saphenous vein. So please remember, infrainguinal bypass is done with veins. What do you mean by in situ vein? See, this is the vein in the lower limb. This is the saphenous vein on the medial side in the lower limb. So what I will do? With this vein, in the same place, I will cut it above and below and anastomose it with arteries like this. I will destroy the walls by valvulotome. So if I'm using in situ veins, I will destroy the walls by valvulotome. Because the direction of saphenous vein is from below upwards, so what I will do? I will destroy the walls and use it as in situ between femoral and popliteal, femoral and tibial. If I'm going to reverse it, no need to destroy the walls. Please remember, if I'm going to reverse it, no need to destroy the wall. So reverse saphenous vein, no need of valvulotome. So these are the commonly done procedures in olden days. See, I'm discussing as olden days. So now what we are doing? Now this type of procedures, bypass procedures, are totally obsolete. Nobody is doing this type of bypass procedures in many centers. People started doing minimally invasive vascular intervention procedures known as angioplasty. So please remember, people started doing angioplasty. The same Seldinger technique, Seldinger needle is passed. Seldinger needle is passed beyond the thrombus, and we put a stent, intra-arterial stent. Intra-arterial stent is placed, so that prevents the occlusion. So this is the latest gold standard. Angioplasty is the gold standard treatment for vascular occlusions today. So though I'm discussing so much about the anastomosis using Dacron, PTFE, saphenous vein, nobody uses them nowadays. Now it is easily treated. Just see here, I will enter from here, go inside and put a stent in this place. Problem over. So this is Seldinger technique and placing of stent known as angioplasty. Okay, angioplasty. Please don't forget these points. Okay, so like this about the peripheral vascular disease, about atherosclerosis, you should not forget. Next time going to the other peripheral vascular disease, thromboangiitis obliterans. So though Bailey displays very few points about it, thromboangiitis obliterans, Bailey displays only very few points. It is not all explaining much points about this because this disease is very rare in Western countries, but it is very common in India, especially South India. This disease is very common. So Shia-Naya criteria. That is a criteria to brand a man as TAO. The criteria is Shia-Naya criteria. What is this criteria saying? There are 5 points to be satisfied. The patient has history of smoking lot of cigarettes, not 1 or 2. He will be smoking 1 packet or more per day. One history of smoking will be there. First important thing is history of smoking, and onset of the disease. Onset should be before 50 years. It should be 50 years or before. And it is seen in 50 years male, before 50 years male. And the lesion present is infrapopliteal only. So please don't forget, it will not involve femoral artery or common artery. It will not involve. It is infrapopliteal lesion only. And it can involve upper limb also. Upper limb involvement will be present, and there will be superficial thrombophlebitis. I told you, adjacent veins and nerves can be involved. So upper limb may be involved. Superficial thrombophlebitis will be involved. Superficial phlebitis will be there. So upper limb will be involved, and superficial phlebitis will be present in Shia-Naya criteria, and there will be no other risk factors. That's a very important point. No other risk factors. For example, if a patient is having diabetic, he will not come under TAO. If a patient is having hypertension, he will not come under TAO. So no other risk factor is a very important point. You should not forget in Shia-Naya criteria. So TAO involves infrapopliteal lesion. It's an infrapopliteal, not a lesion. It's an infrapopliteal occlusion. How is the occlusion? The occlusion is due to sympathetic overactivity. What happens in TAO is there is sympathetic overactivity. There is sympathetic overactivity that is causing this problem. Because of sympathetic overactivity, there is vasospasm. You all know very well, because of sympathetic overactivity, we get vasospasm, and the vasospasm starts from popliteal artery like this. This is popliteal artery, this is anterior tibial, this is posterior tibial, this is opposite limb. Femoral artery is normal, popliteal artery spasm, anterior tibial, posterior tibial. Now you can see femoral artery is normal, external artery normal, and other arteries are normal. Totally they are all normal. The disease is confined below the popliteal artery. And because of vasospasm, since it is bilateral, no thrombus, no occlusion. There will be formation of multiple collaterals like this to the lower limb, like this, like this. What are the name of these type of collaterals? So this is corkscrew collaterals, this is tree root collaterals, spider leg collaterals, or the various collaterals you will see on angiography. Angiography will demonstrate you the various collaterals. And interesting is when you do angiography, everything will be symmetrical in both limbs. It will be symmetrical lesion in both limbs. Young male, symmetrical both limb lesion presenting with bilateral leg claudication pain. Classical feature, bilateral leg claudication pain. A patient has come to you now with a TAO. What are the things you advise them? First thing you advise them is stop smoking. So what are the things you advise them? First, stop smoking. So stop smoking. Do Buger's exercises. Buger's exercises should be done, which increases the collaterals to the lower limb. So what they do in Buger's exercises? They will lie down and they do cycling in the air. They will do cycling in the air with the limb, and some exercises which may increase the collaterals to the lower limb. Buger's exercises will be done. Lifestyle modification. You have to modify the lifestyle. For example, if a patient who is a chronic person who has to walk for long distance in his job, he has to modify his job, go for a sitting job. Like that, lifestyle and job modification advised. Stop smoking. Buger's exercises, lifestyle modification, everything is advised in these patients. And any surgery beneficial means there is only one surgery, lumbar sympathectomy, which may be beneficial. So what is lumbar sympathectomy? So one of the commonly done procedures by vascular surgeons for TAO. So please don't forget that I assume this is L1, L2, L3, the sympathetic chain giving out L1, L2, L3, L1, L2, L3 from the sympathetic chain. Let us assume this is a sympathetic chain. Since it is a disease of bilateral, we have to do lumbar sympathectomy. I told you the vasospasm is due to sympathetic overactivity. So what I should do? I should go inside and cut sympathetic trunk on both sides. At the level of L1, L2, L3 one side, only L2, L3 one side. One side I will preserve L1. Why? Because if I cut L1 on both sides, the patient may develop retrograde ejaculation. These are all young male, so you should not make them roam without a child because of retrograde ejaculation. So please try to preserve L1 on one side. So when you are doing lumbar sympathectomy, L1 should be preserved on one side. Don't forget it. L1 should be preserved on one side. Therefore, please remember in lumbar sympathectomy, L1 should be preserved on one side. So what are the indications of lumbar sympathectomy in TAO? What are the indications of lumbar sympathectomy in TAO? We will do lumbar sympathectomy only for rest pain. Please remember, it is done only for rest pain, ulcer, or for gangrene, superficial gangrene. Only for rest pain, ulcer, and superficial gangrene, we do this. Okay, rest pain, ulcer, and superficial gangrene, we do lumbar sympathectomy. It is contraindicated for what are the places where it is contraindicated? It is contraindicated in intermittent claudication. Please don't forget, it is contraindicated in intermittent claudication pain. Otherwise, it is contraindicated if the ankle brachial pressure index is more than 0.3. So 0.3, if it is more than 0.3, there is not much benefit of this surgery. And it is also contraindicated in diabetic patients. So naturally, we are not going to name them as TAO in diabetic patients, but for completion sake, because in diabetic patients, there will be already autonomic sympathectomy happened. In diabetic patients, already there is autonomic sympathectomy happened, and therefore no use of doing a lumbar sympathectomy in a diabetic patient. So please don't forget, these are high intensity topics. We will do surgery only for rest pain, ulcer, and superficial gangrene. It should not be done for patients who are having only claudication pain, or if the APK is more than 0.3, or in diabetic patients, we don't do this lumbar sympathectomy operation. Okay, are you clear between the atherosclerotic disease and Buerger's disease? Please have a clear idea. Okay, next topic I'm going to discuss is on arteriovenous fistula. Arteriovenous fistula. Please don't forget arteriovenous fistula. So abnormal communication between artery and vein is known as AV fistula. Abnormal communication between artery and vein is AV fistula. The most common cause of this is iatrogenic. We create a fistula for dialysis purpose. It is usually created for dialysis purpose. We created a fistula. That is known as iatrogenic fistula is most common. So most common acquired cause is penetrating trauma. By a knife or something penetrates. Penetrating trauma is the most common acquired cause of fistula. Okay. So overall, the most common cause is iatrogenic by surgeons creating it. Acquired is penetrating trauma, and there are some genetic syndromes which cause this AV fistula. What are genetic syndromes? Can you tell me? The genetic syndromes are Sturge-Weber syndrome, Beckwith-Wiedemann syndrome, and Klippel-Trenaunay syndrome. Actually, it's a controversy whether Klippel-Trenaunay really has a AV fistula or not. Klippel-Trenaunay syndrome we are going to discuss in varicose vein chapter. So about that, this is in detail. So the genetic syndromes are Sturge-Weber, Beckwith, Klippel-Trenaunay are the genetic syndromes associated with AV fistula. So as we have discussed, I told you the surgically created fistula. What is it? It is seminofistula. Seminofistula is a surgically created fistula in the wrist between cephalic vein and radial artery. Please remember, between cephalic vein and radial artery, we create a fistula in the wrist is known as seminofistula, as the most commonly done fistula. So once a fistula is formed between artery and veins, what is the pathophysiology happening? So the pathophysiology happening immediately is there is a arterialization of veins. There will be arterialization of veins. Arterialization of veins will happen. That limb will become long. Limb lengthening will happen. Arterialization of vein will happen, and the pulse rate increases. So please remember, the arterialization of vein, the following features will be seen. So arterialization of the veins will become dilated and pulsatile. That limb will grow much bigger. The temperature will be high in that limb. The pulse rate will be high. So on clinical examination of these patients, you hear a machinery murmur in the anastomotic area. You hear a machinery murmur will be heard, or otherwise we call it as continuous thrill. When you palpate, you get a continuous thrill. On auscultation, you get a machinery murmur. So when you touch it, you have a continuous thrill going on here. At this point of time, you should not forget the commonly used sign known as Nicoll-Danny sign. Nicoll-Danny sign or Branham sign, both are same. Nicoll-Danny or Branham sign, what you should do? So in Nicoll-Danny or Branham sign, if this is the AV fistula here, if you compress it more proximally, immediately the murmur disappears. Swelling decreases, thrill is not palpable, thrill is absent, and finally the pulse rate also decreases. This is Nicoll-Danny sign. On proximal compression of the artery in an AV fistula, murmur, thrill disappears, swelling disappears, and pulse rate decreases. This is known as Nicoll-Danny or Branham sign. Please don't forget this point. Nicoll-Danny or Branham sign. And the last topic in this chapter I want to discuss is Raynaud's disease. Raynaud's disease is usually due to some unknown cause. It is usually due to unknown cause. It can also happen due to scleroderma. Or SLE or some known reasons. It is known as Raynaud's phenomenon. Raynaud's phenomenon usually happens following some disease like scleroderma, SLE. The main problem happening here is vasospasm. The vasospasm of the limb, vasospasm of the hand is mainly due to cold exposure. It is exposure to cold or exposure to continuous vibration. Patient working in a continuous vibration in the machine, continuous vibration, cold exposure. Any of these things can cause this phenomenon, vasospasm. The patients will develop three phenomena in the same limb that is given by the mnemonic WDC. Initially, the limb will look like white. Then the limb will look blue. Then the limb will look crimson red. So this is the limb color in a Raynaud's phenomenon. In Raynaud's phenomenon, what happens is there will be initially white color, then blue color, then crimson red color. What is happening? If this is the upper limb, because of cold vasospasm, the arteries are occluded, the veins are also occluded. The arteries are occluded, the veins are also occluded. So artery and veins both are occluded. So therefore, what happens? Artery, vein, capillary, everything is occluded. Therefore, it is white in color. So now what happens in second phenomenon, that is The artery is still occluded. Artery is still occluded in blue phenomenon. It is still occluded. Whereas the veins will open up. The veins and the capillaries will open up. Therefore, they stagnate venous blood. They stagnate venous blood, and it is actually a cyanosis due to absence of oxygenated blood. And the moment the artery is also opening, the blood flows in an extensive way, and the limb becomes red. So white color is due to both artery and venous capillaries are in spasm. Blue or cyanotic phase is due to artery is still in spasm. The capillaries and venules are opened up. All are opened up. Artery, venules, everything is opened up. Is crimson red. This phenomenon is very rare in India. We don't see this type of cases in India. Just for completion, this is Raynaud's phenomenon, and the treatment is calcium channel blockers. Avoid cold. Calcium channel blockers like nifedipine may be beneficial, not much beneficial, but may be given. And some people also tried with cervicodorsal sympathectomy, like a lumbar sympathectomy. Some people also tried cervicodorsal sympathectomy. But the benefit is doubtful, not much beneficial. It's still doubtful only. So please don't forget these points. Let me show you the images now. Very important. All images you should be thorough in this chapter. So all images are asked in exam. You can see how the embolus is removed by a Seldinger technique. You can see the embolus catheter is entering inside. The Fogarty balloon inflated. We are removing the embolus. As you withdraw it, the embolus is coming out. So this is the important point. So the investigation of choice for these cases is duplex scan. In a case of acute occlusions, we cannot go into angiography. Investigation of choice is duplex scan. Okay? So this is a picture-based question. Fogarty balloon catheter. Embolectomy done in 4 to 6 hours. I told you the difference between atherosclerosis common in old age. Bugus, this is common in 40 years. Major vessels are involved in atherosclerosis. Medium and small size vessels like popliteal and infrapopliteal in bugus. So lower limb only affected in atherosclerosis. Both upper and lower limb affected in bugus. So please don't forget the various obstructions and various features. So please don't forget Lerick syndrome is impotence with a buttock claudication. So buttock claudication with impotence is a saddle embolus at the aortic bifurcation. So this is how they measure the ankle brachial pressure index. So if it is falls high more than 1.3, think of calcified arteries in diabetes and CKD cases. So this is a Doppler is the first investigation, but we have to do angiography. So angiography can show you the left common iliac occlusion. So MR angiography showing you left common iliac occlusion. So you can see we have used a polytetrafluoroethylene prosthesis between iliofemoral. So this is for suprainguinal bypass we use prosthesis. Infrainguinal bypass we use saphenous vein. Okay. So this is Seldinger technique, and please remember this image. This is Seldinger needle catheter. So Seldinger needle, how it will be. So please don't forget, we place the needle, guide wire inserted, needle removed, catheter threaded on guide wire, and guide wire removed. So this is how we use this. So you can see the needle, guide, and the catheter, guide wire, and the catheter. Seldinger catheter will be finally going inside and doing all the procedures. So you can see Seldinger catheter going and removing a thrombus on this side or putting a stent. So like this we do stenting. So you can see in this picture, one by one, there is obstruction of right side artery. Seldinger catheter is going on. The occlusion is relieved by a stenting. So like that it can be used in many cases. So what is Miller cuff from William Dow? So please note this point. Miller cuff is a cuff between the artery and the prosthesis. Sometimes we don't anastomose directly the artery and prosthesis, because if you interpose a vein in between, the anastomotic stricture will not happen, or the stenosis will not happen. So interposition of veins is known as Miller cuff. Interposition of veins is known as Miller cuff. So because this we have discussed, you can see lumbar sympathectomy done on both sides. While doing lumbar sympathectomy, the most important differential diagnosis to know whether you are cutting the sympathetic chain or not. What nerve can cause confusion in that posterior area? The important nerve which you may think it is lumbar sympathectomy and cutting nerve is genitofemoral. Please remember, we can sometimes cut genitofemoral nerve and think we have done a lumbar sympathectomy. So genitofemoral nerve should be noted. So this is AV fistula, arterialization of veins. So Beck-Friedman syndrome, Sturge-Weber-Klippel-Trenaunay syndrome. So this is a local gigantism. You can see the limb is hyperpigmented, enlarged, and have increased temperature. This is Semino fistula between cephalic vein and radial artery. So this is the catheter which we saw already. This is Fogarty catheter. So you can see the 3 phases of Raynaud's phenomenon: white, blue, crimson, red, returning. White, blue, crimson, red. So typical Raynaud's phenomenon. Initially it is white because of ischemia of both artery and vein. Second, it is cyanosis because only artery is ischemic. Then comes red or rubor, crimson red or rubor. It is due to artery opening up suddenly. Okay. So that completes the arterial system. So arterial system is a very important topic. So please follow it. Okay. Thank you.